Okay, so I left off abruptly at the end of that video. Sorry, my son walked in the door and for some reason the little camera stopped working. So just to get you guys caught up on the video that wasn't working or isn't playing on Blackboard, I want to just quickly finish this through the drugs portion. So we were talking about slow channels. So fast channels are exactly what they sound like, and essentially what happens with fast channels is we see a rapid depolarization current, basically a very quick influx of sodium. There is a little bit of calcium, but it's not as significant. And these fast channels are what activates ultimately the atria and the ventricles. So we're going to come back more to these channels later on. So we were talking about the fact that the heart has this capacity for automaticity. And one thing that I want to mention is the influence that the peripheral nervous system has on the heart as well. So as we know from our conversation in the previous unit, both the parasympathetic and the sympathetic nervous systems definitely do exert an effect on the heart. So with the SA node and the AV nodes both have beta-1 adrenergic and muscarinic cholinergic receptors, which means that the sympathetic and the parasympathetic nervous systems will exert an effect on the rate of the heart, which is what the SA node and the AV nodes are governing. So with adrenergic stimulation, which could be via sympathetic stimulation and could also be a result of the adrenal medulla releasing epinephrine and norepinephrine, hitting the beta-1 receptors also. So what we know with adrenergic stimulation, we see an increase in heart rate, and the reason for that is there's an increase in the background influx of calcium and potassium, which means that we're just going to reach threshold faster. With vagal stimulation, which is synonymous with the parasympathetic stimulation, the vagus nerve is the big parasympathetic nerve. And when the vagus nerve is stimulated, that will cause the release of acetylcholine, which will hit our muscarinic cholinergic receptors at both the SA node and the AV node, and that will cause the heart rate to slow down. And the reason for that is it causes the potassium efflux to be accentuated. So more potassium is going to leave the cells, which means the cell will hyperpolarize, which essentially just means it's going to be more difficult for that cell to reach threshold. It's going to take a little bit longer for that pacemaker current to kind of get going. All right, so when we talked about refraction, the refractory period was the time when the heart can't be stimulated to beat again. And there are some things that kind of can be applied to this conversation, not totally directly, but one thing to note is that the AV node is limited to about 200 beats per minute. So what that means is if the SA node is firing at a rate faster than 200 beats per minute, the AV node is essentially going to block it. It's going to kind of disconnect, if you will, which would mean that the atria and the ventricles are isolated. And when that happens, because the ventricles still have the potential to generate a beat, right? Any place in the conduction system can generate a beat, can generate an action potential, which would then lead to a beat. Anytime any place other than the SA node is depolarizing or setting the pace, if you will, we call that an ectopic foci or an out-of-place pacemaker. So in that scenario where the AV node is kind of blocking these really fast impulses from the SA node, if the ventricle generates its own action potential and then beat, that beat would be called an escape beat. And those can be both bad and good. In the scenario that we're talking about here, it's a good thing because the escape beat would allow for blood to actually get out of the heart, right? Without the ability of the ventricles to depolarize, the ventricle wouldn't contract. A circus movement, I'm going to show you a picture of this in a minute. It's also called a REENTRY abnormality, and it's when the same impulse recirculates around the heart. And then finally, fibrillation is another situation where we're not getting a unified contraction. We're just getting a whole lot of electrical stimuli in a very erratic and unpredictable way, and therefore we're not getting an actual beat. So in these situations, sometimes what will be used to kind of try to hopefully reset the heart back to its normal rate and rhythm is electroshock. So what that essentially does is an electric shock is going to cancel out all electrical activity in hopes that the SA node will kind of pick up again. All right. Sorry, I have a hyperventilating dog. So the main pathologies we're going to talk about are congestive heart failure, which is essentially the failure of the pump. And there's all kinds of reasons that the heart can fail, one of which is hypertension, one of which is atherosclerosis, valvular disorders, all kinds of things. It's sort of the end of the road for just about any cardiovascular disease. And what it essentially equates to is that if the heart is not adequately pumping, then we're not able to meet the metabolic demands of the body. I'm going to pause for a second. Sorry about that. So we were talking about heart failure. Okay. Another thing we're going to spend some time talking about is angina, which is heart pain. And that generally is due to a mismatch in the ability of the heart in the supply and demand scenario. So basically the demand of the heart cannot be met by the supply of blood. And that most oftentimes is secondary to atherosclerosis or narrowing of the coronary vessels. And then we'll talk some more about arrhythmias. And they can be due to abnormalities of the rate, impulse formation, or patterns of conduction. All right, let me show you some pictures. So we were just talking about escape beats. I should have shown the picture then. So this is a picture of an escape beat. Oh, for God's sakes, excuse that, whatever that sound is. So an escape beat is where we see the ventricles kind of operating on their own independently. So in this picture, you see the first two QRS complexes are downwardly deflecting, which is perfectly normal. It's just reading the electrical activity in that way. But you notice between those two QRS complexes, there's all kinds of weird waves happening, and those are most likely atrial. And then you see nothing really happening at all. And then you see an escape beat, the first of two, that's labeled with an E, which makes it easy. And you see that the wave of the vector of electrical activity is flowing in a different direction, which just means that the electrical stimulation is coming from someplace other than the normal conduction system. But what's nice about that, and why we call it an escape beat, and why these can be lifesavers, is because that's going to actually get some blood out of the heart, right? This person has probably had a heart attack, and we're not getting any real unified action here. Okay, so a reentry abnormality, again, is where the impulse stimulates tissue that's already been stimulated. And for this to happen, a couple criteria need to be met. Either normal conduction is slowed, or the refractory period is shortened, but in many cases, both things happen. So this is a very common abnormality after someone's had a heart attack. And the reason for that is because with a heart attack, basically there's an area of dead tissue, right? It's a heart attack. Myocardial infarction is defined as necrotic tissue in the heart, which is secondary to ischemic damage. So they haven't gotten blood delivered to their heart, muscle cells, and they die. And when that happens, the dead tissue acts as what we call a unidirectional block, meaning it doesn't block the conduction of the impulse in the normal fashion. Or it doesn't transmit the electrical impulse in the normal fashion. So what you see here in this picture is a illustration of probably what they're trying to draw here is a cardiac muscle cell. And you can see the wave of electrical activity kind of going through and would ultimately lead to the contraction of that cell. So what's happening here is you see starting at the top with the A, we go down, the electrical wave of electrical activity just flows, normally like it would expect, and then it's going to split at the bifurcation. And you see when that B hits that area of dead tissue, it doesn't transmit. So instead, the stimulus continues to go around and out laterally, and then when you get to the bottom where the letter D is, the impulse, normally would cancel out there if it had not been blocked, but instead the D goes up and then it goes back the direction that it came from, and since that's only a unidirectional block, it stimulates that dead tissue. I can't tell you why necrotic tissue only function as a unidirectional block and not a bidirectional block, but that's just the way that it is. And then the impulse is going to just basically circulate again. So it's going to stimulate that tissue that's already been stimulated. All right, I want to talk to you about arrhythmias for a second. So arrhythmias, and we're not going to talk in detail about them now, but we're going to just define a couple terms. So arrhythmias are disorders of rate, impulse formation, and or electrical conduction. So when we think about rate and abnormal impulse formation, we think of first a slow, when the heart rate slows, and that's classified as bradycardia, and traditionally it's when the heart rate is somewhere between 50 to 60 beats per minute. Normal heart rate is somewhere between 60 and 100, probably with the average person being somewhere between 75 and 80 beats per minute. So bradycardia is when it's significantly slowed. Some people have a very naturally slow resting heart rate, and that's normal. People in pretty good physical condition generally fall into that category. And just some people just have a slow resting heart rate. It would be only significant if it was a change for them. If it was their heart rate's normally 80 beats per minute and then all of a sudden it's 50, that would tell us that there's something going on, most likely a blockage of the impulse conduction. If the heart's going faster than 100 beats per minute, anywhere between 100 and 200 beats per minute, that's classified as tachycardia. Flutter is defined as 200 to 300 beats per minute, and that's going to be limited to the atria because remember the AV node can't conduct impulses faster than 200 beats per minute. So atrial flutter is what you'll hear. You won't hear about ventricular flutter, but you will hear about both atrial and ventricular fibrillation, which is really probably what's happening is we're getting impulses that are being thrown at greater than 300 beats per minute, but you can't measure a pulse because you're not actually getting an effective contraction. It's more like pulsing of the muscle, either atrial or ventricular. So that's the most dangerous of our abnormalities. Here's a couple pictures. This is a normal EKG. And there, what you're eyeballing is just that everything looks more or less the same. You're reading different vectors, so each vector looks different, each lead looks different, but when you look at within an individual box there, it looks more or less the same. You can see a P wave, a QRS complex, and a T wave. This is kind of a very exaggerated example of bradycardia, which is actually due to putting pressure on the carotid sinus, which stimulates the parasympathetic nervous system. It causes excessive vagal stimulation. So you can see where that arrow is there. Someone's applying pressure to the carotid sinuses. And what that does is it elicits the parasympathetic response. And you see that it slows way down. And then you see that big distance, that kind of flat line before your next P wave. So that would be way abnormal, right? That's not a classic bradycardia, but it gives us an idea. This is what tachycardia looks like, super fast. The QRS complexes are squished together. It's very difficult to see the T wave. It doesn't look like we really have a T wave. It's just a P wave and the giant, really wide QRS complex. So the heart's really not repolarizing at all before it starts to go again. And this is kind of what atrial flutter looks like. Again, you're just kind of looking at everything looks abnormal there. I mean, look at the distance between your QRS complexes. There's it's not the same. And then you've got all that, those bouncy lines in between the individual QRS complexes. Here's another picture of atrial fibrillation, which is not very clear on this screen. But again, you see all those ups and downs in between the QRS complexes. Heart block is where the AV node is not able to pass all the impulses through. So we're kind of, separating electrically the atria and the ventricles. There's different degrees of heart block. First degree not being a real big deal, and basically what you're going to see is the conduction is just slowed. So how that generally appears is the distance between the P waves and the QRS complexes. It gets longer and longer and longer, but the overall rate is all right. The second degree heart block is there's a couple different types. They're called Mobitz types 1 and type 2, and those are either it gets slower and slower and slower, and then we skip a beat entirely, or we just skip. And then the third is a complete heart block where your atria and your ventricles are totally separate. So we're not going to spend a lot of time talking about this, but we will I just want you to know kind of what heart block is, and it's some sort of block in the conduction of the impulse. All right, so this is where we are going to stop on this video, and we're just going to look at some terms that heart medications oftentimes elicit some kind of characteristic responses. So I want to define those terms, and then in the next go around, we're going to start with our actual first condition, which will be heart failure. So heart medications oftentimes are going to change the force of the contraction, the rate of the contraction, or the rhythm of the heartbeat. And the term for that's in the heart, the contractility or the force of the contraction probably is more appropriate. That term is called an inotropic effect. So the drugs can have both a positive or a negative inotropic effect. When we get into our conversation about heart failure, those drugs oftentimes are classic drugs with inotropic effects because the heart failure is a failure of the pump, right? There's a weakening of the pump. And so in many cases, we would like to give a drug that would stimulate a more forceful contraction. And so that would be a drug with an inotropic effect. If a drug decreased the rate of contraction, that would be a negative inotropic effect. A chronotropic effect is a drug that influences the rate of contraction, both positive and negative. So a positive would increase, a drug that has a positive chronotropic effect would increase the rate of the heart, and the flip side would decrease the rate of the heart. And then finally, the dromotropic effect is anything that influences the conduction through the electrical conduction system of the heart. And once again, it can be either positive or negative. So we're going to pick back up in the next video with a conversation about heart failure.